Okay, hello, welcome back. Now we're on to multiple sclerosis, and we're gonna talk about that a little bit. If I can get the slide to advance. So we're gonna briefly review pathophysiology of multiple sclerosis and identify some drugs, explain mechanisms, indications, interactions, and adverse effects of the drugs used to treat multiple sclerosis. So a little bit about pathophys. We know that the neurons are usually conducting rapidly. Information goes rapidly through the neurons. They're insulated with the myelin sheath, and it gets right to the muscle. With multiple sclerosis, the immune response has been activated by some reason, and there's T and B cells that are attacking this myelin sheath, and they're leading to scarring eventually. And as that happens, then the conduction of the impulse is slowed to the muscle, or it doesn't happen at all. And to fix this, we need to inhibit this immune response that our body is doing so that it cannot attack the myelin sheath and damage the neurons and the conduction. This damage, as it goes on, eventually kills the neuron or inhibits it from totally working at all. So if we can get it early, inflammation can subside, and then not so much of the scar tissue will be formed. Early sign of multiple sclerosis is blurred vision and paresthesias, numbness and tingling. We know that also you get muscle weakness, clumsiness, and spasticity with this. So this immune response is attacking the neurons throughout the body. So the goal for treatment is to prevent this from happening early on so that we can prevent damage. So there's a couple of subtypes for multiple sclerosis. There's the relapsing remitting, which is 85 to 90% of the cases are this. So when you're going through indications for medications, most of them are saying they're indicated for relapsing remitting, and that's because most of the MS cases are this relapsing remitting type. So what happens is you have an exacerbation, and it goes up, and then it goes to remission, and you go back to normal. And what's happening during that time is the body is able to take care of the immune response enough to where the myelin sheaths can be recovered just a little bit, and this is early on. Then it happens again where you have the exacerbation and then the remission. So you see the cycle goes up, down, up, down. You can also have the kind where the cycle goes up, down, but each time you return back to remission, the damage is creeping up so that you don't return to the baseline. So then the secondary progressive type is you go from exacerbation to remission, and then maybe a couple of sessions of that, and then you go right to progressive. So it starts out that relapsing remitting, and then it goes on and shoots up. So the progressive relapse version is you might have, it's progressing, and then you have one plateau or one leveling off time, and then it just continues on to progress steadily again. And then primary progressive, there's no, that's the third one there. It doesn't do any of the relapsing. It might have one level off period, but it continues to progress the disease to worse. So what we're going to look at here is immunomodulators. Interferon beta 1b is the first one to look at. This is the first drug found effective in decreasing the frequency and severity of multiple sclerosis. It actually can delay progression, and it's an ideal treatment to minimize damage to the myelin sheath. This means you have to have a rapid diagnosis and get the treatment on board early. Originally, it was sub-Q injections every other day, and now they have PEG or PEG, which is every 2-week injections. It has a much longer half-life. It's still some sub-Q injections, so there's issues with local reactions is one of the adverse effects. And so one way to fix that, of course, would be to teach rotating the sites. So since this is an immune modulator, it is attacking our immune system, so it causes flu-like symptoms. We know that interferon is part of our immune response that we have living within us. It's a response to viral or other foreign invaders. This drug can cause liver damage, depression, myelosuppression, kind of local reactions. We talked about that from the sub-Q. But we're using it to suppress the immune, so that's why you see the myelosuppression. And also, it's pretty expensive. It can deplete insurance benefits. I was trying to update my info on this, and what I found was it's somewhere between $5,125 to $6,500 for a 1 or 2 dose amount that you have to take, either your once a month or your every 2 weeks or what have you. So it's a pretty expensive drug. And the last thing, interferons are kind of part of our body's natural immune system to fight virus and cancers. So you need to realize that that's going on. You're decreasing or suppressing T cells and reducing inflammation, but also you're reducing the body's ability to fight virus and cancers. So one other drug, glatiramer or Copaxone, this reduces the frequency and severity of multiple sclerosis. It is a once every 2-day injection. So you've got to do a lot of teaching on rotating the sites there. It's a category B, pregnancy category B, so it's safer for young women who may be getting pregnant. So then there's interferon beta 1A, which is very similar to the beta 1B that we talked about earlier, the beta seron. The 2 types of this one are Rebif, which is a sub-Q every 3 weeks. Sub-Q 3 times a week, sorry about that, sub-Q 3 times a week. And then Avonex is an IM preparation that's a 1 time a week injection. So other agents that we have are metoxantrone or novantrone, which is an IV every 3 months, or an outpatient infusion that they would go to an outpatient infusion center to get. It's an immunosuppressant. It's toxic to tissue. The tissue that it's toxic to is the kind that's has an increasing percentage of dividing cells. It's also used as an anti-cancer agent. So cells that rapidly divide include the immune response T cells and macrophages, and fetal cells, so it would cause fetal damage. So this drug, what you have to know, and write this down if you're listening, please pay attention here. Very important to have a pregnancy test before each dose of this drug. Very important. So each time they come to the outpatient infusion, they would have to sit down and get their blood drawn first and make sure they're not pregnant. It is category D on the FDA pregnancy category D. So causes fetal damage. You need to check the CBC also because it is working on these tissues that are high percentage of dividing cells. So you need to check a CBC 10 to 14 days after the dose. It can cause cardiotoxicity, so you need to monitor the ejection fraction before and during at regular intervals. This can even have implications for causing heart failure even later in later years. Let me say one more time with the same thing with this drug, you need to check a CBC 10 to 14 days after the dose to see how it is doing with the immune response and if it's damaging tissue. And of course, we know it has myelosuppressive effects as well. Okay, so with acute attacks of MS, what do we want to do? We're going to want to suppress the immune system, which is right during the acute attack out of control. So you give a short course of glucocorticoids. So you're going to give, steroids of some sort, which would really help with the inflammation and decrease the response of the immune system there. This is another one that you need to remember what to do for an acute attack of MS. Okay, so other treatments that we have, antispasmodics, analgesics, antidepressants. sedative hypnotics. These things are all going to be used based on symptoms of the patient. All right, so that's the end of MS, and we're going to go on to epilepsy. All right, so with epilepsy, we know that this is part of our CNS drug information. We're going to talk a little bit about the pathophys behind the seizures, and we're going to talk about the drugs, explain the mechanisms, indications, interactions, and adverse effects of the drugs that are being used. So we know that with epilepsy, there's a lot of drugs that treat seizures, and we're not going to talk about all the kinds of seizures. Your book really goes into that a lot. We're not teaching you the seizures. We're just going to, in general, talk about it. And even though I might say, oh, this is for tonic-clonic or what have you, other than status epilepticus, you're not going to have to know the different types of seizures. We know that Lamictal is one that is used to treat bipolar depression, and Depakote. The mood stabilizer also, phenobarbital and Tegretol, might be used with this. Benzos, sedative hypnotics, those are all drugs that can be used to help with epilepsy and seizure. These all have increased adverse effects and interactions. So being aware of how the different types of medications are all interacting with each other is something important when you're dealing with somebody who has epilepsy and has all these different kind of classes of drugs on board or being used to try and help manage their disease. Okay, so what is a seizure? What do we do to stop the seizure? We see in this image there's kind of uncontrolled neuronal discharge, and one neuron gets excited and it calls all the other neurons into the chaos, and they're all excited, and then there's just this propagation of issues. How does the one neuron get signal to all these others? The sodium channel is one way. It has sodium's rushing in to do the propagation. And then the other part is the calcium channel. The calcium is also rushing across to kind of propagate this uncontrolled neuronal discharge. So we want to prevent some of this sodium channel propagation, and then also we want to work on the calcium channel propagation. The calcium channel, let me go back. The calcium channel is one that's maybe getting blocked, so where it doesn't go in the right way or the right amounts. Let me go back on that. I might be just mixed up in my notes. Hang on here. Okay, so I'm trying to tell you correctly that this big influx of sodium in the sodium channel and calcium rushing in the calcium channel is kind of what does this propagation. So if you're looking at this image, you see that the anti-seizure medication, one way to decrease this uncontrolled channels rushing calcium and sodium in are drugs that potentiate GABA action. So remember, GABA is an inhibitory neurotransmitter. So the benzos and barbiturates both act on GABA, so that if you're potentiating GABA, which is an inhibitory, you're increasing the CNS depression so that you can relax the brain and not get all of this channel influx. So you're going to delay that, and then also the antagonism of glutamate is going to be another way to help deal with the seizure activity. This thing is never clicking forward when I want it. We'll try this way. Okay, so some goals for epilepsy. We want to stop the seizure if it's happening. Chronically, we view decreased seizure activity for 60 to 70%. We can decrease it with meds to keep them seizure free. The other 30 to 40%, you want to decrease the frequency of the seizure so that you can increase the quality of life. So what I'm trying to say is that in 60% of the people with epilepsy, you can keep them seizure free with the medications. But the other amount, all you're doing is decreasing the frequency of seizure so that you can try and get them the best quality of life. So adherence is, you want to let them know that it's really important not to stop their drugs abruptly. They need to continue as prescribed and keep a seizure diary. Are they still having seizures? And if the seizures are not happening for a period of time, they're seizure free, with this diary, you can tell that's happening. So they may be able to wean off the drug, or with new medication, you're watching, is it helping? Are the seizures increasing or decreasing? Or how do we know which way we need to adjust the new drug? So it's helpful to make sure they know why it's really important to keep the seizure diary. We won't know what's happening unless they pay attention and keep this. So the older drugs, the older drugs like Dilantin, they can have toxicity, they're not being controlled as with the change. So you have to check for therapeutic level. It's important for dosing. It's an older drug, but it still works well. There's a lot more issues with that. So they use newer drugs now because they help to decrease or increase the dose of you know what, I'm not telling you right. The newer drugs, you get an increased dose or change to another drug if the Dilantin is not working and the therapeutic level is messed up. So you need to continue the therapy. Even if they're seizure-free, you wean them off over six weeks to months, and it's really important to keep that seizure diary so that you know where they're at with that. Okay, well, what I was just trying to tell you that I wasn't being very clear about was that with these drugs, you're going to need to keep the seizure diary. And older drugs like Dilantin, they have to draw levels to check for toxicity, and you won't know how they're being controlled and if the change is required. So a lot of drugs you're going to be checking for a therapeutic level, especially with the older drugs. Newer drugs, they're going to increase the dose to match the change to get to the therapeutic level if they're not there. And so that's something important to know about. Okay, let's go to the next thing, which is onto the drugs. So phenytoin or Dilantin, this is an older type of drug, but it's still very effective. It can cause CNS depression. It kind of was heralded as the first effective drug that didn't just totally knock the patient out. It still has quite a bit of CNS depression, but less than phenobarbital, which was the original heavy sedator used for seizures. It can cause less CNS depression than phenobarbital. It inhibits the sodium channels. The therapeutic dose is very near the metabolism limits. So just a little more or hepatic issues, you'll become toxic with this drug. So that's really got a narrow therapeutic window. You want to keep them between 10 to 20 mics per mil, because that's just keeping you kind of mild sedation and it's a therapeutic level. Greater than 20 mics per mil equals toxicity. So you get nystagmus, ataxia, cognitive impairment. So what's important about this to know is that if your patient is acting a little strange and not getting good effects and they're very sleepy, their level might need to be checked, because they should be somewhere in the range of 10 to 20. And if they're greater than 20, that's not therapeutic. And if they're less than 10, that's maybe not therapeutic. So you need to know this range of 10 to 20 is where a therapeutic level is reached, and that's where you want the patient to be. That's how you'll know if they're in the therapeutic range. And I'm trying to make a point so you remember to memorize this fact about the 10 to 20 mics per mil being the therapeutic drug level. Okay, so we talked about the toxicity. Let me get to where I'm at. Let's see. They need to take it as prescribed. Talk about that. Don't stop at cold turkey. Teach about these adverse side effects so they can watch out for increased CNS depression and the hepatotoxic limits, or anything with the liver. Let's see. We talked about that. Okay, IV dosing. That's fosphenytoin or Cerebix is a newer rapid working IV, which it's developed for more safe dosing IV. If you give phenytoin IV, it's not as safe. You get really decreased blood pressure, a lot of cardiac issues, dysrhythmias. So this fosphenytoin is a safer, quick IV push drug to give because if they're in status epilepticus, which we'll talk about later, that's an ongoing seizure, you want to stop that seizure from happening any longer because it's really dangerous respiratory. Everything is involved where the patient's going to maybe die. So you need some rapid treatment, and this IV push rapidly is one of the best things to stop it. Okay, so let's go on to adverse effects. Phenytoin, 20% of the patients get gingival hyperplasia. So they need regular dental visits. They need to make sure you're taught how important oral care is, brushing their teeth, flossing, etc. Also, it's a pregnancy category D drug, so it has teratogenic effects. So this is where you'd want to have the risk-benefit ratio. Talk to the provider with a pregnant woman with seizures, whether she's going to get this drug or not. It has cardiac effects. It interferes with vitamin D, so you can't absorb calcium. And the result of that is osteomalacia because of the decreased calcium levels. So some drug interactions with phenytoin. It induces metabolism. Let's say I'm not saying this right. It induces drug metabolizing enzymes. So it decreases effectiveness of other drugs, oral contraceptives. You may need other forms or increased doses. It lowers levels of coumadin, so they might have increasing clots because the coumadin's not working as well. Glucocorticoids, so you have increased inflammation. Valium, isoniazid, valproic acid, they reduce metabolism of phenytoin. So you want to look for phenytoin toxicity with those drugs. Valproic acid displaces phenytoin from protein binding sites. So what you end up with is increased free phenytoin, which leads to toxicity. So also chronic alcohol use, phenobarbital, those are inducing enzymes. Carbamazepine has accelerated metabolism of phenytoin. So what happens with as a result of those is you get a subtherapeutic level of phenytoin because the metabolism is increased, so it's all metabolized too quickly. All right, so we're going on to carbamazepine, which is Tegretol. It's used for general tonic-clonic seizures, first-line drug. Of course, I'm not testing you on what kind of seizures. I'm just telling you this is a first-line drug. It's safer than phenytoin. It has hepatic metabolism increases with this therapy, so it induces enzymes, so it inhibits sodium channels and slows propagation of sodium channels. So with this one, if the hepatic metabolism is increased, you're going to need to watch out for it not have other drugs not being as effective because they're all metabolized up with this one being on board. Okay, so some adverse side effects with carbamazepine or Tegretol. Of course, we're going to have the neuro side effects: sedation, blurred vision, ataxia, headache. Not horrible, but they're there. And then the hematological ones, you're going to get some bone marrow suppression, so leukopenia, thrombocytopenia. 5% of the patient, if you stop taking the drug, this will help resolve those hematologic problems. You get photosensitivity, so you got to teach them to stay out of the sun or use sunscreen very religiously. They can also get Stevens-Johnson syndrome, which is the rash, blistery rash to the mucous membranes. So if they see that happening, they need to contact their provider. Also, let me back up to the hematological problems. So getting a CBC with somebody on this one is not a bad idea, so you can watch how this bone marrow suppression or anything might be happening. And then this drug, going back down to other problems, is a pregnancy category D causing neural tube defects. So that's something to be very aware of. And the way to decrease neural tube defects is by supplementing with folic acid. So anybody who's pregnant because of seizures on this drug needs to make sure they're getting folic acid. It inhibits, down at the bottom, the interactions, it inhibits phenytoin, phenobarbital, and grapefruit juice. that can inhibit metabolism by 40%. That grapefruit juice is something else. I love it, but boy, it does a lot of things that we didn't really realize. Okay, so valproic acid or Depakote. This one is also taken as a mood stabilizer and for migraines and migraine prophylaxis and for seizures. This is a sodium-calcium channel, works there, and it potentiates GABA. So keeping the sodium and calcium channels from being so inundated, and then by potentiating GABA, you know, we're going to get that inhibitory effect, so some drowsiness with this drug. It also has pregnancy category D for the neural tube defects, and what are we going to give for that? We're going to make sure they're getting folic acid. So 1 to 2 women are, let's see, pregnant while on this drug will have issues within the first month, because we know that this happens early, and many times we don't know that we're pregnant that early. So this is the risk-benefit ratio I'm trying to get at, is if it's 1 to 2 women might have issues with it, but the seizure disorder is so bad, they have to really work with the provider and figure out, do they need this drug, or can we give it with a decreased dose, or what can we do? So if it's for migraines, because this drug can be used for migraines, that risk-benefit ratio is probably going to be a no. You're going to have to put up with migraines in order to not have neural tube defects to your unborn child. So folic acid would be needed if this is something that you decide you're going to have to take. So adverse effects are nausea and vomiting. This resolves over time as you are on this drug, and also it can be given enteric-coated to help with that. Let's see, hepatotoxicity is a problem. Pancreatitis. So with pancreatitis and hepatotoxicity, you're going to be checking liver enzymes, and that can be a pretty serious adverse effect if somebody has pancreatitis, even to where if they don't pay attention, it can be life-threatening. So that's an important fact to remember about valproic acid. And the drug interactions, alcohol leads to excess CNS depression, additive CNS problems with this drug. Also with other anti-epileptic drugs that have sedating effects, that's going to increase the CNS effect. Or if there's inhibiting or inducing of enzymes with the valproic acid, you got to watch how that will affect the level from the other anti-epileptic drugs that you might be on. Okay, so last couple we're going to talk about is phenobarbital and some benzos. We know that these are heavy CNS depressant drugs. The good thing about it, looking at it one way, is using this older kind of heavy CNS depressant drug is that it's cheaper and easier. Has a half-life of 4 days, so once-a-day dosing can be used. It's not used as frequently just because of these adverse side effects and the significant CNS depression. It induces drug metabolizing enzymes, so it interferes with vitamin D. It's a pregnancy D category drug, so you don't want that to happen. It also has adverse effects of toxicity, nystagmus, ataxia, respiratory depression, tolerance with taking it for a long time. And you need higher and higher doses. It knocks out the respiratory drive, so there's a safety point of view here. It's not good for long term. It might be good for status epilepticus because you want to stop the seizure in those cases. All right, and then on to Valium or diazepam, which you've had probably 2 to 3 to 4 to 5 times already. This is a benzodiazepine. It's highly protein bound. The prototype, I think, is lorazepam or Ativan for what we've been given to you guys as information. Its issues are tolerance with long-term use. It also has a long half-life. It can cause long periods of sedation. However, Valium is really good for status epilepticus to break the active seizure, giving it IV. So it's more used for that than it is for actually just preventing seizures. And then newer agents, Lamictal is one adjunctive therapy only is what they used it for initially. Then they decided it's okay to use as monotherapy. They're safer and they're effective. They can cause Stevens-Johnson syndrome, but they're pregnancy category C, so safer for pregnancy. It doesn't affect metabolizing enzymes. It might be affected by the metabolizing enzymes of other drugs if they're using other anti-epileptics or drugs that would be increasing the metabolism. Gabapentin is one that's Neurontin. It is a GABA-like analog, so it doesn't really activate GABA receptors, and they're not really sure how it works, but it is good for migraines and neuropathic pain, restless leg syndrome. Also pregabalin or Lyrica. It's partially used for seizures, used for neuropathic pain and fibromyalgia. Okay, and then epilepsy and pregnancy. So just a little bit more about this. The greatest risk for anyone is during this first trimester where the fetus is being formed, a lot of times before females even realize they're pregnant. They need birth control if they're on epileptic drugs or anti-epileptic drugs. You have to make sure that they're taking birth control and realize they need birth control, and watch for those that are decreasing the effectiveness of birth control. There's this risk-benefit ratio you got to think about all the time. The risk from the seizure, falling, or hypoxia, or induction of labor if you're having the seizure. So you got to weigh that against the side effects and the possible harm to your fetus. With ways to deal with that is just monotherapy, just using one drug over a couple of drugs. That will decrease risks, decreasing the dose so that you don't have as much on board. Keeping the seizure diary so that you can keep decreasing the dose until it's still safe enough, but providing providing anti-seizure, but not as much damage to anybody. And then we want to make sure that they need folic acid, vitamin K to improve the clotting factors because of carbon. I can't say this drug. Hang on a second and let me get the right terminology for you. Yeah, it's carbamazepine, which I'm trying to tell you, and to improve the clotting factor. So just think about things that you're trying to help when somebody's pregnant to give them the best of all outcomes that they can have. Okay, now we're going to talk about status epilepticus. This is a tonic-clonic seizure that lasts greater than 30 minutes, or you can have a break at a couple of seconds and then you go right back to 5 minutes more of tonic-clonic seizure or longer. Also, if you have 2 or more seizures in a row without any recovery. And based on what I was looking up about this, the current treatment for people with status epilepticus is based on if the seizure lasts greater than 5 minutes, no matter what kind it is. As far as having tonic-clonic symptoms, they're going to treat it as if it's status epilepticus. So they don't have to hit that greater than 30-minute level. The best treatment is to start if it's lasting greater than 5 minutes. You want to stop these kinds of seizures. So you have, let's see, you have continuous muscle contractions. The airway is compromised. You get, you may be unconscious. You have tachycardia, increased blood pressure. You get excessive muscle activity, so hyperthermia. Get hypoglycemia. You're using up a lot with this increased metabolic needs, and lactic acid builds up, so you can be acidotic, and also you can have pulmonary edema with this. So this is a big, serious part of epilepsy, and what you want to do is maintain the airway and maintain the ventilation. So be thinking CPR in CPR terms here. Make sure they're getting their airway protected and oxygenation. You want to check for hypoglycemia because you're expecting that to happen. You really want to terminate the seizure. That's also one of the main things after protecting the airway is stop that seizure from happening. So you terminate this with benzodiazepines like diazepam and lorazepam. We talked about that. IV push can be very effective. They are CNS depressants. And so we're going to relax everything by depressing the CNS. The recommendations is phosphonatoin, rapid IV. Even if they're already at a therapeutic level of drugs, you want to stop the seizure, so giving this rapid IV is still a good thing to do. And also you can go on to phenobarbital because that leads to heavy CNS depression. So the point with this is you're going to be hitting them with a lot of things that make CNS depression, and they'll have a big CNS depression effects if you're giving all these drugs. So it should be done in a place where you can protect their airway. They can be intubated. They can go to the ICU. They can be supported with whatever they need to make sure they're not going to die. So it's very important to do this. Let's see. I think that is enough about status epilepticus. And I'm going to take a short break here, and we'll finish with the muscle spasm and spasticity after this. Thank you.